I think that's really great information. Rebecca, you know, I was really struck in listening to you talk that you feel like you really didn't have all the information, that you feel like you would have done immediate breast reconstruction, but it really wasn't offered to you at the time. So we know that treating the breast cancer obviously is the most important thing, but there are these other modalities that are extremely important to the overall comprehensive care of the breast reconstruction patient. So is your advice to other people in your shoes out there now that they need to ask the questions if they're not being provided that information, or they're not seeing a plastic surgeon before they have their oncologic surgery, that they want to see somebody to discuss their options?
Not just to ask the questions, because most breast cancer patients at the outset simply don't know what to ask, but be completely comfortable with your team. Bear in mind that you will have this team for the rest of your life. This team is not going to go away. The oncologist won't go away. Your plastic surgeon won't go away. You need to be extremely comfortable with this team and the treatment that you get from them. If not, find another doctor.
Lou, I know you're an advocate of the team approach to the breast cancer patient, but what are the things specifically that patients should look for in a team that's going to care for them when they have breast cancer?
Well, I think Rebecca hit on two important points. One is being comfortable. And you can't have all the information, and at a time when you're relatively uncomfortable, there should be a sense that things make sense and you are comfortable before proceeding. And so I think if you don't, those are gut feelings that patients have that need to be settled. The second piece, which is more informative, is you would like there to be some uniformity among the people you talk to among the team as to what your treatment plan should be. It's not usually just one plan, there are options. But if you're not clear, you have to get those answers to the point where you do understand or you do feel comfortable. And I think those two things, for the team to be on the same page, have the same philosophy, it just leads towards a better end result. And not all teams believe the same thing, because there isn't an exact answer for everybody, but it makes it much more efficient, and continuity of care is very important when everybody's on the same page.
Thank you both for your great insights today, and Lou, the answers to those questions I think are going to be a really great source of information for our viewers. So please forward this video clip to women you know so they don't have to have any regrets when they're faced with this battle. Welcome back. I'm here with my good friend and colleague, Dr. Lou Buckey. Lou, it's great to not see you at a meeting. How's the trip down?
Good to be here with you, Bill. Trip was easy, and it's just nice to have some one-on-one time.
How's the family doing?
Everybody's good. Everybody's good. Thank you.
So, you know, Lou, known Lou a long time. I think that this is maybe the first meeting between a Philadelphia Eagle fan and a Dallas Cowboy fan that's amicable. So it's good. I think maybe we'll set the tone for future things for the cities.
I don't know if we can have that much of an impact, Bill, but we can certainly start and try.
So, you know, Lou, given your expertise in breast reconstruction, you know, we want to follow up on some of the celebrity awareness that's being done now. We put together a little video montage that I want us to take a look at, and then I'm going to have you comment on some of the critical questions. So let's take a look at this.
Until recently, breast cancer was often a diagnosis of silence and shame. It was often the end of a person's public life, something not to be referred to except when absolutely necessary. In 1974, First Lady Betty Ford's case brought breast cancer into the public eye in a major way for the first time. But even so, the disease remained for the most part a topic outside the bounds of polite conversation. Then in the 1980s, popular television and film actress Ann Jillian was one of the first out breast cancer patients. The Emmy-nominated Jillian, the star of 2 television series and several films, was one of America's best-known performers at the time of her breast cancer diagnosis in 1985. Instead of retreating into the shadows, however, Jillian took her disease into the spotlight. Her battle with the disease was chronicled in headlines around the world. In 1988, Jillian starred in The Ann Jillian Story, the year's #1 made-for-television film in which Jillian portrayed herself. As a result of this film, in 1989, Jillian received a 3rd Emmy Award nomination and won a Golden Globe. Today, the wall of silence that once surrounded breast cancer has crumbled. The candor and visibility of top-name actors, songwriters, television personalities, politicians, and other public figures have made breast cancer a subject for conversation and cooperation. Breast cancer is no longer a diagnosis of shame or silence. Thanks to the courage of patients around the world and from every walk of life, a breast cancer diagnosis is now an opportunity to raise awareness of breast cancer and funds with which to fight it. Their willingness to go public with breast cancer has increased the number of women getting screening for breast cancer and saved countless lives.
Okay, so these celebrities, they're raising awareness about breast cancer and the treatment of breast cancer, but nobody's talking about breast reconstruction. Why do you think that is?
Well, I think that there's probably two answers to that. Breast reconstruction is a relatively complicated topic, but I think from an awareness standpoint, people can understand and relate to if you get the diagnosis of breast cancer. They think about, am I going to live? People don't spend a lot of time thinking about how I'm going to live. And the breast reconstruction aspect actually becomes exceedingly important at the second phase of, I am going to live, now how am I going to live? And so part of awareness, I think, is really more at the first stage, the beginning, the diagnosis. But if you ask patients who've been through the process, how they're going to live is just as important and vitally important. And it's our job to really describe the advances in reconstruction, to describe how good the quality of life can be when all aspects are done together and things are done right.
Yeah, and I think, going back to Rebecca, she is all about quality of life and what breast reconstruction offered as a quality of life measure. So now, you're a fabulous surgeon, Lou. Everybody knows that. How good can a patient look after a breast reconstruction?
Well, there are a lot of variables that determine how good your result can be. Some we have control over, some we don't. And they range from who the breast surgeon is. It even goes as far back as where the initial biopsy is placed, what type of reconstruction they had, what the patient's built like, how they generally heal, whether they need chemotherapy, whether they need radiation. Some of these variables we can control and some we can't. So you need to give a patient, you got to get all the information and then give a patient a general idea of where they fit into that equation.
Now, the other thing I want to ask you about is that in the past 10 to 15 years, the term breast conservation as a technique for treatment of breast cancer has become very common. In some people's opinion, maybe it's even over-delivered to certain patients. Explain to our audience, what is breast conservation and what are the important things that a patient that has a diagnosis of breast cancer needs to know about breast conservation versus the other modalities?
Well, I'll tell you what's very interesting. If you look at breast conservation was initially described as a lumpectomy, a removal of the tumor with radiation to follow. The advantages would be a smaller amount of surgery, and so the ideal patient for the classic breast conservation treatment was a woman with relatively large breasts and a small lump so that it wasn't that distorting. But after radiation, in the concept of breast conservation, I think the whole field got moved to a degree where no matter what you did, you try to just take out the lump and do radiation. And women with smaller breasts and larger lumps ended up having very distorted breasts. On the other end of the spectrum, the mastectomy side of things is really becoming more of a breast conservation treatment because today we save most of the skin. In some cases, we even save the nipple and areola, and we're replacing tissue with similar tissue, so that the mastectomy is almost more conserving in many aspects than the classic lumpectomy and radiation. And sometimes you don't have to have radiation. So at the end of the day, when all things are right, a mastectomy, and some of my patients who've had a mastectomy and reconstruction from 5 feet, you can't tell they had any surgery at all, and that is in itself very breast conserving. So there's getting to be a blur, and the pendulum swings back and forth based on the advances of ourselves and oncologic techniques and mastectomy techniques and radiation delivery.